Okay, so as per the new settings, guys, you can use a chat box option. If you have any doubts, any questions, then please use your chat box option. Okay, so shall we start now with the abdomen scan part? Now, the first thing, can you see this is what X-ray, CT, MRI? Can someone tell me like this is what CT, X-ray, MRI? Anyone? Anyone? Or like any guesses? This is what CT, MRI, or X-ray? Anyone? CT, X-ray, SCT. Okay, CT, X-ray, CT, X-ray. We are getting somewhere. Okay, okay. So I want the answers. Why this is CT scan? Why this is CT, not X-ray? Why this is CT, not X-ray? Okay, so no issue. Now, in today's class, we are learning shining bones, sir. There is no bone shining. This is all your intestine. So on the screen, what you are seeing now is all your intestines. So there is no bone. In our body, we have no bone like this. Okay, so no issue. So in this class, we are discussing around 14, nearby 14, 15 X-rays now about the abdomen scan. There is no CT, no MRI. One image might be with the ultrasound and others will be all of the X-ray part. Now, X-ray usually don't come like this. This is the barium X-ray what we are performing in this patient. Now remember, so if you are having two type of bariums now, in the practice part, we use two type of bariums. So first barium is like what? This will be your meal barium. The other will be what? Your enteroclysis barium. That is nothing but the enteroclysis. CLYCES. Enteroclysis barium. So in the meal part, what we are doing, we are mixing up the barium with the water and we are giving the to the patient. So among such meal barium part, you can witness the abdomen also. Sorry, your stomach also. Correct? What about the barium enteroclysis in which we are putting one tube to the duodenum part and there we are injecting the barium part and we are shooting the X-ray. So what is the difference between all those two parameters? In the meal part, you can appreciate the presence of stomach. In the enteroclasses part, you can also appreciate the presence of stomach if you are injecting in the stomach. Otherwise, there is no stomach will come up in the X-ray part, like what we are having on the screen. This will be more advanced, like this will be giving you more distension. So distension will be more. So if you are having more amount of distension, so automatically we can see more proper amount of margins, we can see more proper amount of mucosa view. Sorry. Okay. I hope this part is clear. So let me show you one more image now. This image, this is what a male barium we are giving. So we can see the stomach is there, followed by the duodenum, jejunum, and ileum. Now, see this image. Can you all appreciate that one tube-like structure is there here? Can you all appreciate? Yes or no? One tube-like structure is there. Yes or no? Let me remove this lines what I have drawn. So can you see this lines like in the stomach, nearby the stomach, some plastic tube is going on in that? Yes or no? Okay. So this is the tube, correct? Can you all appreciate? Yes or no? Yes. So can we appreciate the same tube in the above image? Yes or no? So can we appreciate the same tube in the above structure? Anyone? No, right? Why? This is what a meal animal. Correct? This is what we are giving is a meal barium part. This is what enteroclasses barium we are giving. So you should be able to catch what barium image we are seeing now. Now, what is the benefit by using the enteroclasses part? It will give me the more distension part. So if you are having more distension, then more clear image of the lining of the mucosa now. Now I will tell you how to differentiate between three different part of the intestines, correct? So as per the anatomy, we have three parts of small intestine. Can someone help me? Those are what? Anyone? Those are what? What are the three parts of intestine? Small intestine. Anyone? Correct. Jejunum only one part. Correct. You all are correct. The first part is duodenum, then we have jejunum, then we have ileum. Okay. So I will tell you how to differentiate all these three parameters. Okay. So if you know the anatomy, so the first structure will be what? Out of this three. So first structure will be what? Out of this three. Name me the first structure. What will come first? Duodenum? Correct. Now, if you know the basic anatomy, no, then this is your stomach. Correct. Then this is what? So this is what? This is what? So after stomach, what is coming? Okay, so let me rough it again, then we can have a proper discussion. I will open the chat box also. Okay, okay. Now, if you can witness, let me remove this part as well. Now, just try to focus on this part. This is what your stomach, and after the stomach, we are having some C shape like loop. Yes or no? Can you all appreciate the presence of the C shape like loop? This is nothing but your duodenum. Okay. What about the other two parts? That is the jejunum and the ileum. Remember, jejunum shows like feather-like structure. Okay. Jejunum will show you what? A feather-like structure. So if I zoom in this part, I can see some feather-like structures are present here. Correct? This is what? A jejunum. What about the ileum part? Ileum don't have all this feather-like structure. So we have a plain surface. Okay, this is your ileum part. So I will show you one more image. This image I will show you. Can you all appreciate this finger-like projections or the feather-like projections? Yes or no? Let me remove this part. Can you all appreciate this part? Look at this part and look at this part. Can you all appreciate the presence of this finger-like projections? Yes or no? This is what your jejunum. Correct? Now, can you see the clear difference between the male barium and the enteroclassis barium? See, in the above image, we cannot appreciate clear jejunum part. Correct. In the above part, we cannot appreciate the clear jejunum part. Correct. But we can see that, yes, some feather-like projections are do there. Correct. What about the next image in which we are having the more distension? So that is the benefit of using what? Enteroclassis barium. Correct. So we can have a proper mucosal view. Done. Now this is what your jejunum. What about your ileum part? See, smooth muscles. What we are having the smooth clearance. Like see, yes or no? Can you all appreciate that smooth surface is there, not like the feather positions? Yes or no? Yes. So simple thing. So if you are seeing something coming out after the stomach, that is your duodenum. Then we have the jejunum. Jejunum will be having what? A feather-like projections. What about the ileus? It will contain no feather-like projection. A smooth surface will be there. Remember one more part. If someone asks you in the MCQ, in the Viva, this feather-like projections are known as what? Then this is known as what? A valvulae. This is the medical term for this finger-like projection. This is what? A valvulae. Done. So do we have any doubts, any questions? Anyone? No? Then let me show you one more image. Can we proceed now, right? Do we have any doubts, any questions? Anyone? No? Others? Others? No? Okay. The next image, what we are having on the screen is again the X-ray. We are looking at the X-ray again, but we are giving what? A contrast. We are giving the barium part again. So what we are discussing today is all about the barium part because this is what we can do with the X-ray and the abdomen scans. CT MRI, it's the higher modality that we are covering up in the next class. Okay. Now, if you can appreciate that we do have some incomplete folds. So we are having some incomplete folds, like folds are not complete, right? So this is the clinical feature, the clinical image of what? A large colon. This is what? Your large colon. Done? Can you all appreciate? Yes, this is your large intestine. Yes. Correct, everyone? This is nothing but your large intestine. Correct? Can you all appreciate? A clear differentiation is there. See, you can differentiate small intestine, large intestine very easily, but you can't differentiate the three parts of the small intestine. So, what are the clinical features? What features you should be seeing on the radiological images? The feather-like position. Something is coming out of the stomach. C shape is there. That part is what? A duodenum. You are having some feather-like projection. That will be what? Your jejunum. No feathers, smooth surface is there. That this is what? Your ileum. Correct? What about the colon? You can completely appreciate the colon. Remember, if you are giving the enteroclysis, then you can't appreciate the large colon very easily. So, if you want to appreciate the presence of the large colon or the large intestine, you have to give what? Barium enema. Barium enema you need to give. I hope you all know what is enema, right? So from the same route, we have to give barium and automatically then we can shoot the X-rays and we can have a proper clear image. Correct? Now this is what? Your rectum, this part. Then you're having your sigmoid. Then this is your ascending colon. This is your transfer colon. This is your descending colon. And this is your sigmoid, then rectum and the ends. Done. So this is how you will differentiate the this parts. Simple, everyone? Yes or no? Simple. Others? So do we have any doubts with respect to the large or small intestine? Do we have any doubts now? Or like everything is clear? Clear, right? Yes or no? Clear, clear, clear. Okay, done. Perfect. Now let me take one more image now. I am showing you one more image. This is what? Can someone guess? This is what? Now, if I show you the zoom part of it, I can see that some finger-like projections are there. Correct? Some finger-like projections are there. So this is what? Bhavnish, we are coming for that part. Don't worry. I will show you all the possible images. But as such of now, you please focus on the current images, what we are discussing. Okay, so my first question, can you all appreciate the presence of these finger-like projections? Yes or no? Let me remove this part. Yes or no? Can you appreciate or not? This will be what then? This will be what? Jejunum? Will I? No. Jejunum, jejunum. Correct. Good. This is nothing, your jejunum. Okay. Now, if you are seeing this type of image, in the radiology part, we discuss this as the step ladder sign. This is your first ladder. This is your second ladder. This is your third ladder. This is your fourth ladder. So if you are seeing such type of images in which we can appreciate the ladder formation is there, then you can definitely make the diagnosis of what? Small intestine obstruction. Small intestine obstruction, a clear diagnosis you can make. Now, in the small intestine obstruction, my next question will be, is this proximal? Is this proximal or the distal part? Because in question they will ask such part. So if you can see this image, so in exam pattern, suppose this image is coming to your exam in KMED also. If I ask you, tell me, if I tell you the diagnosis, you will tell me that small tunnel obstruction is there. But if I ask you the more category out of it, is this proximal or the distal? So we should be able to answer such questions also. Now for the proximal part, remember, let me rub this all lines. Remember, proximal will be what? The upper part. What about the distal part? The lower part. Correct? Now in the upper part, if you are seeing this step ladder sign, that means it involve only jejunum. Correct? What about the lower part? If you can see that small ladder shine like its presence in the lower to the upper part, then you make a diagnosis that jejunum, jejunum and ileum both are obstructed. Correct? So if you can see the step ladder sign is there from below to the up. This is what? A distal small intestinal obstruction. If you are noticing only the upper part, like in this image, this is what? A proximal diagnosis. Correct? So let me remove this all lines for your reference. Correct? Now here we are having the stepladder sign in the above category, but in the pelvic part, there is no stepladder sign. So I can tell that my patient is having jejunum obstruction. Yes or no? This part is clear. Remember, for the proximal, only jejunum will come. For the distal part, we are having jejunum plus ileus. It is there in the pelvic region. This is the pelvic region. Done, everyone? Done? Do we have any doubts, any questions? Anyone? Any doubts, any questions now with this image? No? Others? Done? Clear? Which part? Snehita, which part? See, the thing is very simple. Let me remove this diagrams first. See, if you can appreciate the presence of this step ladder sign. Okay, let me change the color. If you can appreciate the presence of the step ladder sign only in the above part, this is what your proximal distension. Okay, this is what your proximal small intestinal obstruction. Correct? What about if you are seeing the step ladder sign again in the pelvic part also and pelvic and the above part, then I can conclude that my patient is having what? A distal small intestinal obstruction. So this is how you will make the diagnosis where you are able to see the step ladder sign. Done? Done, Snehita? Done? Others, do we have any questions, any doubts? Done? Now I have one more question to you. Suppose this obstruction patient is coming to you. So can you give barium enema or barium meal or the barium enteroclasses? My question is very simple. Suppose one patient is coming to you with a like we are suspecting a patient having the small or large bowel obstruction. So can I give barium enema or barium meal or barium enteroclasses? Anyone? No? No? Why no? Enteroclasses? No. We will not give. Abhi, it is not the common site for the obstruction because after stomach, automatically food will come up to the jejunum part. So there only you will have more distension. Sorry, more obstruction. Sorry. Okay. Others, why we should not give barium or any contrast medium? Tell me. Because they need a more distinction image. So entero. No. My thing is like, my question is very simple, yes or no. So answer is what? A straightforward answer that is no. We should not give a barium to our patient where we are suspecting a obstruction is there. Why no? Because barium is not a water soluble. Barium is not a water soluble compound. That means it will be stay there for a long time. Correct? So suppose if you are having a perforation, so even if patient with the perforation or the obstruction, in both the cases, we should not give barium. Okay. Why not? In the case of perforation, what will happen? Barium will come out of the intestine, and barium is what? Not a water soluble. So it will be there for a long time. Correct. So barium in the abdomen cavity will cause more irritation, more inflammation, more infection, and more sepsis. Patient can die. What about the obstruction? Obstruction patients, if you are giving the barium enema, it might lead to the perforation. Perforation will happen, then more infection, more inflammation, sepsis, and patient will die. That is what we should never give a barium enema, barium meal, or barium enteroclysis to our patient in which we are suspecting what? Obstruction. So what we can do, we can give a iodine based contrast. So if you really want to give the contrast among some certain conditions, then we can give a iodine contrast. This is water soluble, will not cause any inflammation, will not cause any infection. Done. So do we have any doubts now? Anyone? Clear? Okay. Let me discuss one more image now. Now again, what we are seeing is what X-ray part. There is no contrast what we are giving, but we can see something is wrong in this image. So what we can suspect now? Any guesses? What we can suspect? Any guesses? Anyone? Inflammation? Inflammation of what? No? Okay. Now just try to follow my line, what I'm going to draw now. So can you all appreciate this image? Can you all appreciate this image? Yes or no? Correct? This is what your large intestine obstruction. Large intestine obstruction. Remember, you just need to follow the other image. See, just try to follow this image. Correct? Now just try to follow the next image. The what we are not doing, we are not giving the contrast. So that might be causing more confusion among you people. Like this is what? Correct? But there is no distal obstruction. This is a large bowel obstruction. Correct? This is how you have to identify whether my patient is having proximal, distal, or the large intestine obstruction. Done, everyone? Now, let me discuss few more things with you all. Now, first, let's discuss about the small intestine obstruction. Now, the first thing what we are dealing here is the small intestine obstruction. Correct? Now, if I ask you, so let's compare small versus large intestine obstruction. So, which is more common? So, what part to see? Can't make it clearly in previous image. In previous image, this image, Mohit? Yes? Okay. Now, see. Mohit, just capture this image in your mind, this image of the large colon, this image of your large colon. Just capture this image and just capture this image. Can you see now, Mohit? Yes, so this is how you will make the differentiation. Now back to my question. If we are having small intestine and the large intestine obstruction, which will be more common? Small or large? Tell me why. Okay, small, small, but why small? Why not large? Tell me. Again, my question is very simple. If you are telling small, then why small? Simple X-ray. It is only simple X-ray what we are doing. 2D X-ray. Small because of the diameter. Okay. See, the problem is in the large intestine, the small intestine. If I ask you like which region is more prone to the small obstruction or the major obstruction, the answer is of course small intestine. Okay. What is the main cause for the obstruction now? Surgery. Why surgery? Because if we are performing the surgery, the most common complication is what? Additions. So additions are the main factor responsible for the small intestine obstruction. So what about the large intestine now? In the large intestine, we don't do all these things. Okay, addition surgery will not happen as such. So the most common cause for large intestinal obstruction will be what? A cancer. Cancer is the most common cause for large intestine obstruction. Now, if I give you the simple management, now if I'm asking you what is the management for the small intestinal obstruction, so what will be the answer? Anyone? Do you know how to manage patients with the small intestine obstruction? Anyone? Anyone? Surgery? Surgery will do afterwards. But what is the first management? Nothing. You admit the patient. First step will be what? Admit the patient. Then what? 24 hours NPO. You put patient on IV fluids and wait for 24 hours. Automatically it will resolve. Correct? If it is not resolving, then of course we need a surgery for that management part. Enema we will give for the other part. Not now. Don't worry. I will tell you. Enema part. Done, everyone? Done? This part is done? Yes or no? Yes, yes, yes. Okay, what about the large colon now? In the case of large colon, the most common responsible factor is what? A carcinoma. correct? So can we wait for 24 hours NPO thing? Yes or no? Can we wait for 24 hours NPO thing? Yes or no? Simple question I'm asking. Can we wait? Of course, no. We can't wait. So, of course, we need to send our patient for the surgical management. Done. So, this is the most commonly asked questions also. If somebody is there from the MBBS, from the preparing for the NEET PG also, this were the most commonly asked questions in the NEET PG exam as well. So remember, so if you are dealing here, someone here with a NEET PG or FMGE exam, remember in the last exam, last year exams only, they have asked for the distal and the proximal part with the help of an image. So this is will be helpful for you. Okay. The next image what I am showing you is the esophagus now. So this will you learn automatically with the experience part. Okay. Now this is what your esophagus that is completely dilated. Correct? This is what your esophagus that is completely dilated. And can you all appreciate the smooth lining in the end? Can you all appreciate the smooth lining in the end? Yes or no? Let me remove this part. Can you all appreciate the presence of the smooth lining in the end? Yes or no? Yes or no? Yes, this is what a clinical feature of achalasia. This is nothing but the achalasia. So achalasia is what? Nothing but the lower GI disorder problem in which the motility will be less. Correct? If you know that in our entire GI tract, that movement will be there, right? Some certain movements will be there to move the content forward. So automatically what will happen in the achalasia? This GI movement will be completely lost in the lower esophageal part. Correct? So what will happen? Patient will tell you that if I eat food, it's like it feels like my food is stuck in the neck or in the lower neck region. This is the most problem they will complain you. Okay, that is what achalasia is. Now the next question: what is the investigation of choice for the achalasia? Anyone? So remember in the GI tract, if any patient is complaining about the obstruction or the feeling like something has stopped in between, we need to follow what? A CT scan. We can perform endoscopy also to cross check if something is there or not, like obstruction, like cancer. If it is not, then the investigation of choice for the achalasia or the movement disorder will be what? A manometry. A manometry. So upper GI manometry we can also do. We can do lower GI manometry as well. So manometry will automatically catch whether we have or not the loss of movement. Correct? Do we have any doubts now? Any doubts? Anyone? Any doubts? Anyone? No? Everything is getting simple. No? What is manometry? Manometry is nothing but a type of investigation in which we are checking for the GI movement, how much movement is there or not. Because in our GI tract, we have some certain movement, that is the peristalsis, from which your food and content will move forward. So in the absence of the GI movement, your food and water will not move forward. Okay. So to evaluate the movement disorder, we have to perform the manometry. Treatment is nothing. Treatment is the poem treatment. So this is a surgical procedure done endoscopically. So this is the poem. So poem we have to perform. This is the name of surgery, poem. So this is what we perform to treat the achalasia part. So remember, so if you are seeing such image in which we are getting the clear margins, suspect what? Achalasia. Achalasia is what? A complete loss of lower GI movement. Oh, sorry, esophagus movement. Done. So what going to happen? So if I ask you what is the investigation of choice, then of course manometry. Okay, but if patient is not allowing us to perform the manometry, so first thing what we can do is the endoscopy. So from the endoscopy, we can remove the suspicion of what? A cancer or the tumor obstruction. So if suppose endoscopy is coming completely normal, so what we can do, we can perform the manometry to evaluate the GI mortality. Done. What is the reason for such dilatation of esophagus? Okay, you remember you all people. The thing is, our esophagus, our intestine is not the open organ. These are the collapsed organ. Correct? So if you're eating food, no, then only it will be opening. Afterwards, it will be a completely collapsed organ. Remember this part, Mohit. This is for you specifically. Your esophagus, your intestine is not the open organs. These are the collapsed organs. So if you are drinking water, you are drinking food, sorry, eating food, then only it will allow to expand. Otherwise, this will be a complete a collapsed organ. Correct? Now, if in the last part, if it is not able to move the food, so what is going to happen? The upper esophagus will automatically expand because the lower part is not sufficient. That's why. So this is nothing but the compensation process. Done. That is why the upper GI is totally expanded. Sorry, upper esophagus is totally expanded, not the lower esophagus. Done, Mohit? Is swelling something? No, this is a barium. See, this is the X-ray. Something is shining. No. Compare with the last images what we have learned. See, shining, shining, shining. So this is what? Again shining. Correct? This is the barium what we are giving. Okay, done? Done, everyone? So this part is done. Let me show you one more image now. Again, here we are having the esophagus. Now, can you see? Now, please try to focus on the lower image, this image. Now, we are not having the smooth surface. Things are going here and there, correct? We are having some irregular surface. Can you all appreciate? Yes or no? Yes or no? Can you all appreciate this part? Yes? Yes or no? Okay, so in any image of CT, MRI, even the case of pathological features, not sure for the pathological features, but I'm sure for the radio features. So if you are seeing some irregular patches, irregular surface, always think of cancer. So always think of what? A presence of cancer. If radiological image is showing something irregular here and there, something is moving here and there, some stars are coming, something is coming, irregular shape and size. So always think of what? Cancer. Now done. Now suppose if I send you this image and I ask you for the investigation of choice. So your answer will be what? I'm asking you a simple question. Your investigation of choice will be what? Okay, I will give you some small options. First is upper GI endoscopy, lower GI endoscopy, then PET scan, then I'm giving you suppose upper, sorry, esophageal ultrasound, endoscopic US. Answer me one thing. Which endoscopy now? Endoscopy is correct. Which endoscopy? Yes, upper GI endoscopy. But for what? To take the biopsy. Done. To take the what? Biopsy. Now let me ask you one more question for the same image only. Now suppose if I want to check the staging of cancer, if I want to check the staging of cancer, then what I will use? PET CT, EUS. EUS is nothing but the endoscopic ultrasound. Upper GI endoscopy or lower GI endoscopy? Answer me. Histopathology part has been done, Bhavnesh. This is the part. For this part, I am asking you, I want to check for the staging now. Correct? If I want to check for the staging, what I will perform? PET CT, EUS, UGIE or LGIE? Answer me. PET scan answer is wrong. PET CT is not the answer. Histopath not the correct answer. Answer me. EUS, correct. Why EUS? Because for the staging, we need to check the tumor involvement, tumor invention, how many systems are developed. Okay, so with the help of EUS, EUS is nothing. We perform the endoscopy, and the end of the scope we have small probe for the ultrasound. So we are actually performing the ultrasound. So from this part, we will get the how much my tumor is spread, how much vein arteries it developed, and how much it invention is there for with the other organs. So with this help, we can stage the cancer part. Done. Now, if I ask you one more question, suppose I want to check whether this is a metastasis or not, then what will be the investigation of choice? Is it PET CT? Is it EUS? Is it upper GI endoscopy or lower GI endoscopy? Anyone? PET CT. Correct. This is the correct answer. PET CT. So if you want to check for the metastasis, you need to perform what? A PET CT scan. Done, everyone? So do we have any doubts, any questions now? See, I need to give you all these things in brief also, because otherwise if something come up, then you should be able to answer. Then, so if you are seeing this image, you are telling that patient is having cancer for sure. But next what? Then you should be able to answer the next steps also. Perform upper GI endoscopy, take this tissue sample, send for the pathological examination. What about the staging part? Perform the EUS. What about the metastasis? Check for the PET CT. Correct? So we are not limiting you with this only image. I want to make it clear like what next stage we need to perform. Done, everyone? Done? Do we have any doubts? No, there is no differential. This is the common step, Dr. Ram. Like we have to perform all these things. Done? Staging part, I will tell you once I have the staging wala images. Don't worry. For this part, Ashutosh, I can help you with the liver part. I have some images for the CT MRI that I can help you. Don't worry. That staging part, I can't tell you in this image. Okay. So let's discuss one more image now. Again, this is what the esophagus. This is what the esophagus, what we are dealing here. Okay. Now, remember in the case of radiology, we do have some certain unique names. We have some bullseye, we have some corkscrew sign, we have some river flow sign, we have some sandwich sign, we have some snowman sign. All things are coming up. But the problem with the signs are like is what? It can be mimic the other sign symptoms also. The image is what we are getting. Now, technically, this image, as per the test books, some are reporting as the corkscrew, reporting as what? A corkscrew. But if you ever seen some Google images, you might find some river flow like this in this. Are you all like agreeing with the same part? Yes or no? Have you ever seen images of the river bodies? It is moving like this only, correct? So this can be a river flow sign also, this can be a corkscrew sign also. Okay, so multiple names will be there, but you need to practice proper radiology, so make the diagnosis. Don't rely on this unique names what we are giving for the memory part. Okay, now in this image what my patient is having is the DES, diffuse esophageal spasm. So nothing is happening. Remember, in our GI tract, a lot of movement will happen. Okay, a lot of spasm will happen, from which your food will move forward from esophagus to stomach, from there to the pyloric part, then to the small and the large intestine. Correct? Now, in this diffuse esophageal spasm, what is happening? A rapid movement is happening. A rapid movements are happening. So such patients will be directly reporting to the trauma center, or they are reporting to some cardiologist. Why? Because this will mimic the MI sign and symptom. So DES will mimic what? Your MI. So such patients are directly reporting to what? A trauma center and the cardiology department for the evaluation. So if they perform all the evaluation, your ECG, your echo, all will come normal. So what we have to do? We have to perform the barium X-ray, or we can perform the manometry. Why manometry? Because spasm is coming up. Correct? So manometry only catch those spasm. Done, everyone? Simple? Simple discussion? Yes or no? Yes or no? Any doubts? Any doubts? Clear? Okay. So let's discuss one more image. This is ultrasound, what we are performing now. Now, let me zoom in this for you people. Let me change color also. I guess this is perfect. Okay. Now, please try to focus on the image. Here we have something black, black. Here we have something black, black. Yes or no? Can you all appreciate? Yes or no? Yes. Others? Visible, no? Correct. This is what air. So I can tell that air. So if I can see such image, in many books, this is nothing but a donut sign. In many books, this is nothing but a sandwich sign. So again, we are having two different names, but again, your practice should be handy in your hand. So you can be able to make the diagnosis. So if I am seeing such image, I can directly tell that my patient is having what? Interception. Interception. So what is interception? So this is your small intestine, this is your small intestine. So what is happening in the interception is like your one intestine will move backward into the previous intestine. Correct? This is nothing but two part of the intestine will collapse together. Done. This will be what your interception. Now what how to treat interception? Can someone answer me? Anyone? How you will treat the interception? Anyone? Surgery afterwards. Surgery is the next option. So first is what? First is what? Surgery is secondary, of course. GI movement increase. Yes, correct, Dhruva. Dhruva is going in the right direction. But from where? If I ask you, Dhruva, from where? Upper or lower? Okay. So I do have one X-ray also. Okay. This is the X-ray what we are having, and here we are having the interception. So in this patient, if you perform the X-ray with barium, you will notice this image. This image. So from the rectum we are giving the enema, correct? From the rectum we are giving the enema, correct? So it is coming upward, correct? Now what will happen? This will start to push. So barium we are pushing, no? So of course we are putting some pressure with the barium. So of course it going to push. So what will happen? Afterwards, this will again to getting open afterwards. So afterwards it will keep opening and this will remove the what? Interception. Done everyone? Yes or no? Yes or no? Any doubts? Any questions? Repeat once. Okay. Now in this patient, I can see that interception is present. In this patient, I can appreciate with the help of ultrasound that interception is present for sure. So what I will do, I will admit this patient. I will give the lower GI enema. So what I will notice that enema is not moving afterwards. So if I shoot the X-ray, it is coming up to this part only. Let me remove this part. So if I'm shooting the X-ray, enema stop till here. Okay, so but I know that patient is having the interception, but not the obstruction. Remember, it is not the obstruction. What we are having is the interception, correct? So with the help of pressure, what is going to happen? Automatically that intestine that collapsed, it starts to getting uncoiled. So you will notice this type of pattern afterwards. This type of pattern with the enema, barium enema. That means it is resolving now. So this is the treatment also. So if you are noticing your patient is having the interception, admit the patient, you give a pressure enema, automatically it will resolve. So we are not limiting ourselves with the barium. So if you want, you can give water enema also. If you are sure, you can give the air enema also. No problem. But for the practice part, for the on the safe part, we use barium only. So we can appreciate by the using of X-ray also. Because air and water will not come up in the X-ray, barium will come up. That's why we are putting barium and we will shoot the X-ray. Done, everyone? All doubt clears? Any doubt? Any questions? Clear, no? Okay, so let me take one more image. Okay, perfect. Okay, now I will have one quiz with you all. I have this image. I have this image and let me take this image as well. Let me mark 1, let me mark 2. So 1 is what? Answer me. 1 is what? 1 is what? Okay, so let me make it more simple for you. I will not make this much complex. Okay, so this is 1, this is 2. Answer me. Esophagus, no. Jejunum, correct. This is what? Your jejunum. Then this is what? Second one. Ileum. Correct. You need to focus on the feather-like projections. Correct. Now, this is your ileum. This is what your ileocecal connection. Correct. Now, let me remove all these things, question things for you people. Now, can you all appreciate the presence of a small string-like signature? A sign is there. Yes or no? Can you all appreciate? Yes or no? Let me remove this part. Can you all appreciate the string-like structure here? Yes or no? Others? Yes or no? Correct. This string-like structures will happen in two conditions. First is what a TB, a second is what IBD. If I ask you what, like which type of IBD, then Crohn's IBD. Remember this part, Crohn's IBD. So if I'm giving you a diagnosis, a image with this string-like structure, two diagnoses can be made, that is a TB and the IBD. Which IBD? Crohn's IBD. Now, if I ask you next question, what is the investigation of choice? Answer me. So after this image, we need to confirm whether my patient is having TB or IBD. So the next is what? So investigation of choice is what afterwards? Anyone? Mantaps. No. We can do mantaps. Barium. No. What is the investigation of choice afterwards? This is the barium already. No. USS guided biopsy. No. Endoscopy. Correct. Correct, everyone. See, I think someone has asked for the USG guided biopsy. No, this is, see, intestine is not the fixed organ. This is the mobile organ. So if you are performing the ultrasound, the major problem is the air molecule. Air will come up in between and you can't take the biopsy also. Correct? And if you are putting the needle, it will move here and there. So more patient problem, more patient pain will complain. Okay. So what we can do, we will perform the colonoscopy. We will perform the colonoscopy. We will take the tissue sample for the biopsy and send for the pathological examination. Pathological examination we need to perform. So this is your investigation of choice. Colonoscopy. Correct? Now let me show you one more image now. Correct. Now in this image, can you all appreciate the large intestine? Yes or no? Can you all appreciate the large intestine? Yes or no? Correct? Does it look like a pipe? If you ever have used pipe for the watering, does it look like a pipe? Yes or no? If you ever went to a garden for watering the plants with a pipe, no? Does it look like a pipe? Correct? So if you appreciate the presence of pipe-like appearance, this might be what here IBD. But which type of IBD? Anyone? UC. So this is how you will make the differentiation, whether my patient is having UC or the Crohn's disease. Remember, UC will be where in the colonoscopy part only. We can only appreciate the presence of UC where in the colon, large colon, but not for the entire GI part. Remember, this is your trick now to remember the IBD for this part. Okay, now this is what? Can someone answer me? The most common available image on the Instagram also. This is what? So if I show you this image of the large intestine, this is what a large intestine for sure. So this is what? What diagnosis can you make? Perforation? No. What diagnosis can you make? Remember the simple rule of radiology. If you are noticing some irregular, funny stages, funny shape size, always think of what? Cancer. Good. So if you are noticing some funny shape, some uneven shape and size, always think of what? A cancer. So this is what? A cancer. Done. Colon cancer. Yes, everyone. Correct, correct, correct. Fine, fine. Good, good. Yes. So I hope this part is done. So if you go to the Instagram, if you go to the Google search for this image, this will be coming up like what? Apple core sign. This is what looks like the apple that we have eaten the apple. This is what apple core sign. This is what cancer. Done, everyone? Simple till now. Everything is going fine, right? Yes or no? Yes, everything is going fine, right? No confusion, no doubt. Simple things we are discussing. This is all the basics, first of all. Yes, X-ray, no, Bhavnish. The thing is, Hypoechoic, hyperechoic lesions will come up. But the problem with the intestine is like you are having a lot of air in the intestine, so it will inhibit the ultrasound diagnosis. So what we do, we perform the CT, MRI, or the X-ray with the barium part. Okay. So ultrasound is best for the liver, for the spleen, pancreas, and all those structures. So if you are dealing with the permanent fixed structures, then USG is best. But in the intestine, it is a long intestine, lot of air will be there. So ultrasound biggest enemy is what? Air. Remember the simple principle. The biggest enemy of ultrasound is what? Air only. That's why we are putting a gel before doing the ultrasound. Why? Because air is the biggest enemy. So that is why we should not perform ultrasound for the intestine. Nowadays, we are practicing a high definition, high ultrasonic probes for the diagnosis for IBD, but we are not doing at every center. So remember this part, okay? Let me take one more image. Oh, this is the last image now. And this is the most complicated image now. So this is what? So this is what? Can someone answer me? This is small or large intestine? Answer me. Large intestine or small intestine? Large, large, large. Everyone happy with the large intestine answer? Sure, no? Okay. So you are like, all are correct. This is what? A large intestine. Correct. Now, if I'm putting the barium no, in this patient by using the enema, suppose we are giving barium enema, correct? And I'm noticing this out pouches. Multiple out pouches are visible to everyone. I hope this is visible to everyone. This part, can you all appreciate? Yes or no? The small, small dots nearby the sigmoid colon. Yes or no? So if you know the anatomy, this is what? A rectum, sorry, anus, then rectum. Then we are having what? A sigmoid colon. Take it. This is what? Your sigmoid colon. Correct? Now, sorry, let me rub this part. Now, if you notice such things on the barium enema X-ray, directly you can make the diagnosis of what? A diverticulum. My patient is having what? A diverticulum. Diverticulum is what? A small outlet, a small pouch will create in the sigmoid colon. Now, now suppose this patient is coming to you. Suppose 54-year-old male patient is coming to you with fever, with abdomen pain, correct? Suppose this is 101 degree Fahrenheit and X-ray show this feature. Then diagnosis will be what? Diverticulitis. Diagnosis will change to what? A diverticulitis. That means infection is there in the small out pouches. Correct? So if there is no fever, patient is completely fine, no abdomen pain, but we can see some small pouches, this is what? A diverticulum. If patient develop fever, abdomen pain, all symptoms are coming up, WBC is elevated, neutrophils elevated, think of what? A diverticulitis. Infection is there now. So we have to start what? Local antibiotics. We have to start the antibiotics to treat the patient. Correct? Now, let me try to collect one ultrasound, one lower GI image. I need to search my database once, but I'm thinking I have this image for the reticulum in the endoscopy part. If I got, then I will share the same with you all in the groups. No issue. Okay, this part is done. Now, little bit more advanced, I'm giving you for the diverticulosis. Remember, the most common region for the diverticulosis is what? A sigmoid colon. Why sigmoid colon? This is thin in nature. So comparatively, if we are comparing the entire colon, so sigmoid is little bit thin in compared to the other part of the intestine. Okay, now here we follow the Laplace law. We follow what? A Laplace law. This Laplace law is what? Your wall tension is equal to what? Pressure into radius upon thickness. Correct? Now, if your thickness is less in the case of sigmoid colon, so what is happening? Your wall tension will be more. Correct? If you are having constipation, you are not taking good diet rich in fiber. You have to put lot of pressure while passing the stools. So if you are having more pressure, then more wall tension. Correct? What about the radius? Compared to the other part of the intestine, large intestine, we have a small radius for the sigmoid. So more the radius, less the wall tension. Correct? So if you are putting a lot of pressure while passing the stool, you are creating a lot of wall tension among the sigmoid colon. Correct? Its thickness is already less. So what is going to happen? So pressure and the thickness both will contribute to what? A development of diverticulosis. Correct? Now what will happen? Now suppose this is your sigmoid part, this is your diverticulosis. Correct? So what will happen? Your food will come, your stools will come and will start to accumulate in the diverticulum. Then it will start what? Infection. So once you have infection, then automatically you will develop the inflammation. So once you have the inflammation, then more swelling will come. More swelling, lesser the thickness. Then rupture will happen. Correct, Dhruva? Rupture will happen, then perforation will happen. More perforation, then sepsis and death. Correct, everyone? Done? But remember, usually patients who are aged like 60 plus, they are more prone to develop what? Diverticulum. How come? Because this is the connective tissue disorder. So with the aging, we are losing our connective tissue. So this is what? A connective tissue disorder. So automatically such patients will develop the diverticulum afterwards. Correct? So this is what about this image. No, Mohit, no. Done, everyone? So do we have any doubts? Prognosis part for which, ma'am? Crohn's disease part 1, diverticulitis. Okay, okay. So let me answer once ma'am's part, and we can go to your question, Ashutosh. Ma'am, see, if you are having a diverticulosis, only diverticulosis, not infection. So what we are going to do, we have to increase the fiber-rich diet. Fiber-rich diet we need to improve, because if you are having more fiber diet, automatically you are creating more bulky stools, and automatically it will come up. Now, if you are having diverticulitis, then like nothing to worry about. Nothing will happen in one shot. So start the antibiotic therapy. So start the antibiotic. Remember, for the local region, what we usually use is the Rifagut. Rifagut 550 mg. We commonly use twice a day for 2 weeks. It will automatically resolve all the infection part. Afterwards, start what? Again, fiber-rich diet. Afterwards, start what? A fiber-rich diet. Fiber-rich diet means it will automatically creating bulk to your stools, and automatically it will pass out. So if your stools are bulky, then there is no need to put lot of pressure while passing the stool. Done, everyone? This part is done. Probiotics, you can see. Now the problem with the probiotics, no, Bhavnish, is like suppose I have seen many prescriptions. It is coming like suppose you are giving Rifagut 550 milligram twice a day. They are giving, suppose, let me take one more probiotic. Suppose Lactogut we are taking, they are giving 101. Okay, but the problem with this prescription is like what? Lactogut contains some pre and probiotic. If we are giving Lactogut or any prebiotic, probiotic with the antibiotic, this antibiotic will going to kill the prebiotic and probiotic as well. So we should not give together. At least we should maintain 6 hours gap between the antibiotic and the probiotic or prebiotic. Done, everyone? So what we can do? So Rifagut we cannot change. This is the practice. 101 we need to give. So for the Lactogut, what we can do? Make 010. So automatically patient is maintaining 6 hours of gap. Done. So this is not the patient thing. This is our thing. Okay. So like this is our duty to change the prescription to make the prescription well and fine for the patient. Correct? Now, if you're giving Rifagut for 2 weeks, you give Lactogut for 2 weeks in such way, then start 101 for the another 2 weeks. Because we have given lot of antibiotic, we need to regenerate the good probiotic, prebiotic for the flora of the intestine. That's why give 101 for the next 2 weeks. Once Rifagut is over, make twice a day for 2 weeks. Done. And I think someone has asked for the Crohn's disease also. Yes, Ashutosh has asked for the Crohn's disease. Okay. This is the image what we were discussing, Ashutosh. So in this part, if you can appreciate the presence of the string sign, just try to follow my marker. This is the string sign. You will notice a fine white line is there. A very fine white line you can appreciate. Sorry. Yes or no? Ashutosh, can you appreciate this part? Ashutosh, can you appreciate this fine white line? Correct. This is what a spring sign. This appears like a spring sign. Correct. Now this can happen in two cases. One is what a TB. Other thing is what a Crohn's disease. Now, if you are noticing such part, we are not a fixed diagnosis we are having. Either my patient might be having TB or the Crohn's disease. So what I can suspect of? Anything. So next step will be what I will perform the colonoscopy, in which what I will do, I will evaluate the colon, correct? I will like I can go to the intestinal setting part as is with my colonoscope. Okay. Then what we will do, we will take the biopsy. We will send for the pathological examination whether my patient is having TB or not. See, the problem is in practice also, if we perform the colonoscopy to make the diagnosis for IBD, we are not sure whether my patient is having IBD or not. Why? Because IBD features of the intestine and the TB looks like same. So here comes your experience. So if you are performing the colonoscopy, you should be able to catch with the image, yes, my patient is having what? A Crohn's or the UC, but not TB in that part. But still, to be on the safer side, we perform biopsy and we send for the pathological examination to rule out the TB part. Done, Ashutosh? This part is clear? Ashutosh? Kumar, because both appears like same in the colonoscopy. That's why. So there your experience will come in handy. You should be able to diagnose on the image basis. Yes, this is TB. Yes, this is IBD. That's why. Okay, done. So do we have any more doubts, any more questions? No, Dr. Rang, no. Symptoms also overlap with each other. Others, do we have any doubts, any questions? Can surgery, Shilpa, it is surgery. Of course, you can use. This is the well-known marker for the IBD, calprotectin. But in the practice, we use CRP also. Thank you so much, Pushpanjali ma'am. Done, everyone. Do we have any doubts, any questions? Thank you, Manish. So I think we can wind up now if we have no more questions or doubt. In the next class, we are starting with the liver pathology. Like we will discuss more about the liver part and the renal part as well. But the IBD is not curable. See, it is not like curable. It is like IBD is nothing but the inflammatory stage, Dr. Rang, for the intestine part. So what we can do is like we will give the patient a lot of medication part to remove the inflammation. That's it. It can be curable, like it is. See, it is not curable, of course, but we can easily manage the IBD. Okay, so I think we can wind up now. If we have no more doubts, questions, then we can wind up. Okay, thank you so much, everyone.